Right, this is the ribs, and there are a lot of things about ribs, and we're going to tell you about different ways to approach the ribs and the rib cartilages and the sternum and different things in that area. But we're going to also tell you a little bit right now about what medicine has to say about it. Now, for example, Capangie's volume 3, the trunk and vertebral column, page 134 to 5, says rotation of thoracic vertebra subjects sternum to shearing forces. Well, how in the world can it do that? It does it because of the connection to the ribs and the rib cartilages. So therefore, according to Capangie, the thoracic area, the ribs, and the sternum all act as one unit. And I gave this in a class, and a female chiropractor called me back a few weeks later, all excited. She said, "I heard you say that," and something really perked up in my mind. She had this fellow that a house fell on him. A house fell on the guy. And they got rid of all the pain in him, but they couldn't get rid of the thoracic pain. And she heard me say this out of a medical book, Capangie, volume 3. And she thought, maybe that's what I'm missing. So she followed, she said, all the protocol for adjusting the ribs, rib cartilages, sternum, and his thoracic pain totally went away. So she wouldn't have thought of that unless I'd said this. And I'm just telling you, if you got a problem with the thoracic cage, it may be because of the ribs and the sternum. And I want you to start thinking about that as one unit. Now here's something else out of the medical literature. Modern manual therapy of the vertebral column. This is chapter 50, examination of the thoracic spine. Well, in this, it talks about numbness of the legs, usually below the T6 level. The patient may complain of paresthesia below the level of the lesion and a feeling of tightness around the chest and abdomen, as well as numbness of the trunk or legs. So, and it also says every patient showed some weakness of the legs. So you take that together with Capangie, and you may have been treating the thoracic area, but you didn't get the ribs and the sternum, as it would affect the thoracic area, and therefore cause numbness of the trunk or legs and weakness of the legs. So I hope this is tripping something in your head. This is some value I get out of reading other medical literature. Also, it says thoracic joints and dura mater. When the anterior chest pain is present, the possibility of sternocostal joint and Costo-Chondral junction lesions contributing to the symptoms should not be forgotten. So anytime you're thinking of the thoracic area, you have to think, because it's one unit, of all the ribs and rib cartilages and the sternum as one unit. And if you miss that, you may be missing something very, very big on that particular patient. Here we're looking at the first and second ribs. We're going to look at adjusting them on the front and on the back. Now, one of the problems that I feel, and I did this because I was taught to do it, is we normally will have somebody face down and we will cross the arm over and we will take the head one way and drive the rib the other way. And I found that, yeah, I might get an audible, but it seldom did what I actually wanted it to do. And then I got to thinking, when we catch something, when we're holding something, it's a downward force here and it pulls those first two ribs out. It doesn't jam them in. So with that in mind, I started looking at adjusting the ribs from lateral toward medial instead. And you can probably do this laying down, prone if you want to. I prefer sitting. You take your thumb and you place it on the head of the first rib in the back. And while you're doing this, you're going to take the head and you're going to take the head into the rib, and you're telling the person, dip your head over, and you're going to lift the head back, and you're going to rotate it one way or the other while you're holding a medial force, lateral toward medial force on the rib head. You're going to feel one point, and it may be with the nose totally toward the side you're adjusting. It may be in a more neutral, it may be totally away, you don't know. And basically you're going to, at the same time, counter thrust the head one way. Now what you see here is the fingers are on the neck, and the palm, the thenar is basically on the ear, while you're holding your thumb in a lateral to medial type of force. And you find that point where you feel the most restriction, and you counter thrust. The head goes that way, the thumb goes that way at the same time. Many times you'll get an audible, and again this might apply to the first or the second rib. Now you have the front of the rib, which can do the same thing. Here you take the index and middle finger pretty straight like this. You're going to go behind the clavicle like so. You're going to take the head just the same way, only this time instead of extending backwards, you're going to drop it a little bit forward. And you'll notice that that changes the pressure on the front part of the ribs. And you're going to again rotate it, and you will feel the point where it sticks, and then you give a counter thrust right there. And this will take pressure off of the brachial plexus and the brachial arteries. And a lot of structures attached to that first and second rib, mainly the scalenes. The scalenus minimus, the anterior scalene, the middle scalenes, all attached to the first rib. Posterior scalene attaches to the second rib here. And that's going to relieve a whole lot of things on the neck just directly, because it's going to change the stress on those muscles as they attach to the cervical vertebra, and it's going to relieve pressure on the nerves and the arterial structures that go all the way down the extremities and in the chest and upper back at the same time. Now we're going to talk about the costo-clavicular joints. So you have the clavicle, and you have the ribs just posterior to the clavicle. And when there's a friction behind them, it causes a hang-up and can cause a lot of symptoms. For example, when you press on the scalenes here, you press on the subclavicular here, pectoralis minor here, upper trapezius here, and these are symptoms. You've been trying to work on the trigger points, you've been working on maybe the first rib adjustment, the cervicals, the shoulder, and it hasn't been going anywhere. This provides an immediate relief for that because it gets rid of this friction. Now what's happening is all these muscles are trying to protect that particular joint because it's not moving properly. And the way that you take care of this is have the patient sit. You're going to go to the middle of the clavicle, just under it with your thenar right in the middle, just like so. You're going to apply a posterior superior pressure. Now as you do that, you're going to bring the head down, and right when you reach the end of the range of motion, you just give a very slight thrust, very slight, doesn't take much. And immediately you go back to these structures that were just immediately very painful, and there's no pain. The tightness is gone because that joint's moving. They don't have to protect it anymore. Here we're going to look at the sternum. And sternum, basically you have the manubrium, which goes from the sternal notch. You'll feel a ridge about right here, roughly about 2 inches or so below that. Then you have the gladiolum, which is the blade. Then right at the tip of it you have the xyphoid process. Now the manubrium, as it articulates with the gladiolus, can cause an issue with the shoulder, the head of the shoulder, the humerus. So when you press on the head of the humerus, right there, they're going to hurt, okay? And that's because this joint is not moving properly, and it's affecting the pectoralis major as it goes over to this area, and it's going to cause a lot of issues that way. So what we're going to do is we're going to take the thumb on the manubrium itself and the thumb on the gladiolus. We're going to shear against each other. Remember, my idea of the subluxation is somewhat different. You're not moving one bone, you're moving one bone as it relates to the other bones. We're going to shift both of them. So you're going to shear just like this, and you're going to shear the opposite direction. And you're going to compress, and you're going to cross the thumbs over and distract. And you're going to put pressure down and tap, and you're going to get A to P. And those are the basic motions here. And as soon as you're done with that, you can go right back to the head of the humerus, and there'll be no pain. It's just that quick. Now the xyphoid process down here is somewhat different, okay? On the back of it, the diaphragm attaches, and it goes directly to the cardiac sphincter, which is the sphincter between the esophagus and the stomach. So when the joint between the gladiolus and the xyphoid is not mobile properly, that's going to affect the opening and closing of the cardiac sphincter. So if it remains open, then you are going to get an acid reflux, and you'll get a hiatal hernia. First time I did this, I showed this in Salt Lake City, and a chiropractor, an older gentleman, said, I've had to sit in a chair for 32 years because of hiatal hernia and acid reflux. I said, well, come on up. So we did this on him. Basically, the xyphoid fishtails. There's that joint there. Basically, it can shear one way or the other, but the biggest motion is the fishtailing. And so I had him come up, and I got on it, and basically you're pressing one way, and you press the other way. Now you notice in this subject, there's a lot of movement going this way. There's no movement going this way. So you're going to take the xyphoid detention on this fishtail, just like that, and now you have movement. Now you also may have the xyphoid flipped up, and you all have patients like this. So what you do is every time they come in, you take the finger on the tip of it, press down, and give it 2 or 3 taps just like that. You'll find that over a period of time, it will lower down and go back to its normal position. So you're going to have a lot of changes just from doing those 2 particular procedures. Right, here we're looking at the Chondo-Chondral joints, just adjacent to the sternum. I'm kind of proposing that because a lot of people, that's not really named anywhere. but I'm proposing that because that's actually what it is. Now, most people don't really realize it, but the rectus abdominis actually attaches as high as the 5th, 6th, and 7th ribs, which can be way up in here. Okay, may go a little higher because there is variation in that. But it comes down and attaches to the top of the pubic bone, which is right here. So when you have an abnormal tonus, it's going to be painful on the top of the pubic bone where that attachment is. Now, because of the abnormal tonus, you're going to have other symptoms, because that's going to cause the pelvis to rock forward or backwards. When it does it, it's going to affect the true pelvic floor, the ischiococcygis and the pubococcygis. So if you go basically just inside the ischium with your thumb and you press just on the inside of it all the way up to the pubic bone, you're going to notice on one or both sides that that's going to be painful. You have the person laying there with their feet together, knees bent to 90 degrees, and just dropped outside just so it's comfortable like that. Also, because it's rocking the pelvis, you're going to have a constant low back pain or tension on the other side. So you have a lot of reactions that are going on here. Now, any pelvic organs that sit on that true pelvic floor are going to be affected. For example, the prostate sits right on the pelvic floor. So when you take care of the rectus abdominis abnormal tone, not only are you going to relieve the pain and tension here, it's going to affect, for example, ED, prostatitis, BPH, benign prostatic hypertrophy. It's going to affect bladder incontinence, retroversion, anteroversion, prolapse. You're going to have uterine prolapse, vaginal prolapse, anteroposition, retroposition of those particular organs. It's going to cause an issue of pressure on the lymphatic flow. So therefore you're going to have issues with, for example, polycystic or ovarian disease, or just ovarian cysts by themselves. So when you take this pressure off the rectus abdominis way up here at the other end, then you're going to affect that. So how do we do that? Well, first we find them. You're going to take one thumb and you're going to press, and it's going to be sensitive. So you just find where the sensitive ones are. Like I said, it may go up even to the second or third one. So basically we've located anywhere from the 4th to the 7th rib cartilages just adjacent to the sternum. And you're going to take your thumbs and you're going to shear them one way. So all this means that there is scar tissue and that everything's being hung up between these cartilages. So you're going to thrust one across the other just like this. And you're going to shift your thumbs and go the opposite direction. Then you're going to compress them. You notice I'm doing this in 2 lines. Then you're going to cross the thumbs, you're going to distract them. And you're going to take direct A to P on either side. And as soon as you've done that, maybe let it wait about 10 seconds or so. You immediately go down to the top of the pubic bone, and now there's no pain, because you've taken the abnormal stress off of the rectus abdominis, which was protecting these joints up in here, the Chondo-Chondral joints adjacent to the sternum. And you go back directly to the pelvic floor just inside the ischium up to the pubis, and that pain is gone. Then you have the patient stand up. You say, okay, how's your lower back? They will notice that the pain or the tension has gone out of the low back as it relates to the abnormal tone of the rectus abdominis. Now we're going to talk about the Chondo-Chondral joints as it relates to the abdominal muscles. So it's basically the ones in the upper abdomen. And they have Chondo-Chondral joints. They come up from under like this. And you have all of the joints from about 8 through 10. And it doesn't include the floating ribs, which is 11 and 12. And so the joints themselves are right here, right? Now, before you do these, you can press in the upper quadrant just below it. So this would be the left upper quadrant. This would be the right upper quadrant. Anything just under that, you may have some severe pain. You're going to find that after you adjust these, that pain will be gone just immediately. Now, what you have is you have a shearing. So you're going to take a contact, the one above, the one below, shear right to left, left to right, and then shift the thumbs the other way, and you're going to compress them, and you're going to cross the thumbs again and distract them, and you're going to take a firm pressure, take straight A to P. You wait about 10 seconds, you go immediately back, and the pain is diminished or gone virtually every time. Now, one of the other things that this does is it releases the diaphragm. And this is real important because the diaphragm by the cruise attaches down to the body of L3, and the upper part attaches up to about T5. Here we have the same thing with T5 on the rectus abdominis muscle and T5 on the diaphragm, but this is a direct attachment. So if you have people that have been having trouble with pain, tension, anywhere from L3 up to T5, you can't get rid of it, it's probably because the diaphragm isn't functioning right. This is one of the ways to release that, as well as the pain just below that on the ipsilateral side. Now we have the joints between the cartilage and the sternum. I think unfortunately it's called in the medical literature Costo-Sternal, where it should be Chondro-Chondral joints. Basically, you go from just below the clavicle all the way down to just above the xyphoid. And here you want to be like Muhammad Ali, float like a butterfly, sting like a bee. You're going to counter play on a shearing basis, superior to inferior, thrust, 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 and you're going to change thrust, 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 going just the opposite direction. Then you compress together, cross, distract, and you're going to take a pressure down on the gladiolus and manubrium, and then on the chondral cartilages, just like so. And here, that's going to take care of a lot of chest pain right in this area, but it's also going to take care of pain roughly about 1 inch to 2 inches below the coracoid process right here, which you normally had thought of as being a deltoid or pectoralis minor, coracobrachialis, pectoralis major type of issue. And it's basically these joints here where you have an attachment of the sternal portion of the pectoralis major as it goes across that area. And basically it's protecting this joint. As soon as you release that joint, then this particular pain will go away. Here we have the Costo-Chondral joints. Now, along with the Costo-Sternal joint, as we stated before, these can affect and cause trunk and leg numbness. And they can cause leg weakness. So please don't forget that. Now, the Costo-Sternal joints angle. just like this. You can feel the ridge as it angles up at that junction. It goes just inside the nipple, starts maybe an inch or so out from the manubrium, just under the clavicle, and angles just inside the nipple going down here. It can also contribute to breast and chest pain and trouble with lymphatic drainage and etc. And here you're going to do about the same type of movement as you did with the Costo-Sternal joints. Float like a butterfly, sting like a bee. You're going to apposition your thumbs, thrust, 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 just like this, and switch them and shear the other direction. Then you're going to compress, and you're going to cross the thumbs and distract, and you're going to press down, straight A to P on one side, and then the other side. Now we're going to talk about the Costo-Costal joints, and I'm kind of coining this term as well as the Chondo-Chondral joints besides the sternum. Basically, the serratus anicus attaches to the anterior border, nearly the whole superior border of the scapula, medial border, and the lower angle of the border. So it goes over most of the scapula on the anterior side, which most people don't really realize that. And it attaches from the 1st through the 9th ribs in the axillary area. Then you have kind of a mixing here with the external abdominal obliques in approximately the same area, and it melds with the internal abdominal oblique on the contralateral side. Now, and it attaches from basically the 5th rib through the 10th rib. So you have an overlap of the 5th through the 9th ribs between these areas. And when you release this, you're going to see a lot of things happen. For example, when this is involved, there's basically always a pain where the contralateral internal abdominal oblique attaches, which is Poupart's ligament, and that attaches the ASIS down the pubic bone on the contralateral side. So you press there, and there's groin pain that you haven't been able to affect, and you didn't know why. Now, we'll have our subject sit up here, and since the scapula attaches to several muscles besides the serratus anicus, for example, the pectoralis major, the pectoralis minor, the coracobrachialis attaches there, all the deltoids attach there, both of the bicep heads attach there, the long head of the triceps attaches there, the latissimus dorsi attaches the posterior inferior border aspect of the scapula. All the trapezius muscles attach to it, and all the sits muscles attach to it. So you have a huge variety of muscles that attach there. So here's a person that no matter what you do, no matter how many times you release all these muscles, you still have all this shoulder pain, or you still have that contralateral groin pain. So when you free up the Costo-Costal joints in the axillary area, then automatically let it rest for 10 seconds. You go back and you retest the contralateral Poupart's ligament, the pain's gone. And you go back and you repinch on all these areas that are attached to the scapula, and virtually all those have let up without ever going near them. Basically what happened with this patient, they fell on their side, they got hit in their side. Now, everything in the body is protecting that axillary area. So when you free it up, Now all these muscles don't have to protect it anymore, they release, and basically all of those trigger points were just reactionary, trying to protect the costo-costal joints. So you free up the costo-costal joints, now the trigger points aren't needed to protect it anymore, and they just automatically release without ever treating them. So we're going to take this patient and have him lay on the right side. And put the arm up like so. And so basically we have from about the 5th rib down to the 10th rib down in here. And remember that the ribs angle downward from back to front, like so. And just imagine a line going right through the middle of the axillary area, then one forward, maybe an inch, inch and a half to that, one backwards, an inch, inch and a half to that. So we're going to take the thumbs, we're going to shear one way, one the other way, just like so, and go down through those real quick, float like a butterfly, sting like a bee. Then we're going to shift and we're going to shear them back the other way. Then we're going to compress them, and we're going to cross the thumbs and distract them through this area. Then we're going to take and press down, basically straight lateral to medial. And you let them rest about 10 seconds, and you go back over all these areas that were tender. All or virtually all of them have let up, and the opposite groin has let up. Now we have the Costo-Vertebral and Costo-Transverse joints, and they would have the same effect as adjusting the thoracic vertebra, but you have to address these, and a lot of times they are what are causing the thoracic vertebra not to hold properly. In addition to that, you can have other symptoms, such as for example when you have the lateral branch of the dorsal rami of T2, it doesn't emerge superficially until it hits level T6, and then it ascends up to the acromian process. So the acromian is here, therefore it can affect adversely the acromioclavicular muscle and the pectoralis minor muscle. So therefore this would affect the acromioclavicular joint, also the deltoid and the trapezius, which attached to it could be affected. You also have the T4 syndrome. Now the T4 syndrome can affect the whole head, the skull cap, the skull cap area, like so, and the whole hand, the elbow to the hand, and the shoulder through the hand. Any of those areas could be affected, usually bilateral. So if you have those descriptive symptoms, look at the T4 area, the T4 syndrome. Now for these joints, again, we're going to float like a butterfly and sting like a bee. Basically, you want to shear first, so you're going to place one thumb on the vertebra, the other on the rib head, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and then shear the opposite way. Then you're going to compress, and you're going to distract, just like that. And it's just that quick and easy, and you get amazing results by releasing these joints.